In this video, we'll be discussing the axilla and the arm. Let's begin with the anatomy of the axilla, which is the armpit. The area of the axilla is a pyramid-shaped space wedged between the lateral thoracic wall and the shoulder joint. The axilla is an area of passage for neurovascular structures that serve the upper limb. You have already been introduced to the muscles that form both the anterior and posterior boundaries of the axilla. For example, the anterior axillary fold consists of both the pectoralis major and pectoralis minor muscles, whereas the posterior axillary fold is comprised of the subscapularis muscle, the latissimus dorsi, and the teres major. The intertubercular sulcus of the humerus, also known as the bicipital groove, is considered to be the lateralmost boundary of the axilla. Here's the intertubercular sulcus, with the long head of the biceps brachii tendon seated within the groove. And the medialmost boundary of the axilla is considered to be the lateral thoracic wall, which is covered by the serratus anterior muscle. At the apex of the axilla, there is an opening through which a neurovascular bundle passes. This opening is formed by the boundaries of the first rib and the clavicle, as well as part of the scapula, and it's known as the cervico-axillary canal, shown here. And lastly, the base of the axilla ends at about the fourth intercostal space. This is also the same region where the axillary tail of Spence in female breasts extends toward the mid-axillary line. Within the axilla, you will be identifying the axillary artery and all of its branches, the axillary vein, the nerves of the brachial plexus, and you might find a few lymph nodes. Along with those structures, you're going to find and pick through a lot of fat. During lab, on approach to the axillary artery and its branches, you'll be dissecting through the axillary sheath, shown here. This sheath is a cotton candy-like covering of deep fascia derived from the cervical prevertebral fascia in the neck. The axillary sheath completely envelops the neurovascular bundle, and it continues distally into the upper arm, where it happens to blend with the intermuscular septum of the arm. Here in the lower right of the screen is a cross-sectional view showing the axillary sheath, containing the neurovascular structures. Within this sheath, it is possible to acquire a hematoma, which can compress part of the brachial plexus. As you can imagine, direct compression of a nerve may cause demyelination of axons, resulting in transient conduction block, leading to downstream deficits. Breast surgeons, when they're working in the upper limits of the axilla, try their best not to breach the axillary sheath, so as not to cause downstream neurological defects. One important goal of the axillary dissection is to identify all of the branches of the axillary artery. At the lateral border of the first rib, the subclavian artery changes names to become the axillary artery, which then gives off 6 branches, before it changes names again to become the brachial artery. This dotted line here represents the inferior border of the teres major muscle. This is the transition point where the axillary artery becomes the brachial artery. As has been discussed previously, the pectoralis minor is a very useful landmark for a variety of different structures, including the axillary artery. The first part of the axillary artery lies between the lateral border of the first rib and the medial edge of the pectoralis minor muscle. The second part of the axillary artery lies just deep to the pec minor, and the third part lies between the lateral edge of the pec minor and the inferior border of the teres major muscle. Coming from the first part of the axillary artery is one branch. From the second part, there are 2 branches, and from the third part, there are 3 branches. The first artery arising from the first part of the axillary artery is the supreme or superior thoracic artery, which arises just beneath the subclavius muscle and it mainly supplies the muscles of the upper two intercostal spaces. Before I go any further, I want to first mention that the axillary vein is going to obstruct your field of view to visualize the axillary artery and all of its branches. As such, you'll need to resect a large segment of the axillary vein. To do that, you'll divide the axillary vein just distal to the location where the cephalic vein enters the axillary vein. You'll make a second cut along the inferior border of the teres major muscle. Once both of those cuts are made, you'll resect that segment of axillary vein to visualize the axillary artery and all of its branches. Coming from the second part of the axillary artery are two branches, the first of which is the thoracoacromial artery, shown here. This artery tends to emerge at the upper medial border of the pec minor muscle, or just behind the pec minor, near its attachment onto the coracoid process of the scapula. This artery, as you might recall from a previous video, gives off four different branches. Recall that cadavers are dead people, so the branches that arise from the thoracoacromial trunk include the clavicular artery, acromial artery, deltoid, and pectoral branches. The second artery to emerge from the second part of the axillary artery would be the lateral thoracic artery. This artery is going to course along the lateral border of the pec minor, and as its name suggests, it's going to supply the lateral thoracic wall. More specifically, the lateral thoracic artery will supply the serratus anterior muscle, the lateral breast, part of the pectoralis minor muscle, as well as some axillary lymph nodes. The third part of the axillary artery has three branches coming from it. Those branches include both the posterior and anterior circumflex humeral arteries. Notice that the posterior circumflex humeral artery is typically more proximal to the anterior artery, and notice that it's also larger in diameter. These two features will help you to identify it in lab. These arteries anastomose with one another around the surgical neck of the humerus. And the third branch, coming from the third division of the axillary artery, is the subscapular artery. This trunk immediately gives off both the circumflex scapular artery, which heads toward the back of the scapula, and it also gives off the thoracodorsal artery, which, as you already know, this artery supplies the latissimus dorsi muscle. And to reiterate, once the axillary artery crosses the inferior border of the teres major muscle, it changes names to the brachial artery. And very close to this transition point, the deep brachial artery, demonstrated here by the star, is given off. As you are already aware, arteries tend to be susceptible to occlusions, from atherosclerotic plaques, for example. Well, thankfully, there are several collateral pathways throughout the body that allow for an occluded vessel to be bypassed through an alternate route. The scapular arcade is one example of a collateral pathway. Here we have the posterior view of the subscapular artery, shown here, dividing into both the thoracodorsal artery and the circumflex scapular artery. Let's suppose that we have an occlusion of the suprascapular artery in the area demonstrated here by the X. Initially, you might anticipate that the supraspinatus and infraspinatus muscles would be affected. However, because of the anastomotic connection between the suprascapular artery and the circumflex scapular artery, blood can still reach and supply these muscles. Here's the area of anastomosis between the suprascapular and circumflex scapular arteries. There is also a smaller anastomotic connection between the thoracodorsal and dorsal scapular arteries as well, near the inferior angle of the scapula. So in the instance of this occlusion, instead of blood taking the route of the suprascapular artery, it instead takes the route of the axillary artery to the subscapular, to the circumflex, and back up through the suprascapular artery. And this is how this occlusion would be bypassed. To quickly reiterate, for the purposes of dissection, you'll have to remove the axillary vein in order to visualize the axillary artery and its branches. To do so, you'll cut here, just distal to where the cephalic vein enters into the axillary vein, and you'll also divide the axillary vein along the inferior border of the teres major muscle. The entire section of axillary vein will then be resected so you can visualize the underlying vasculature. The axillary vein is a deep vein that is formed by the union of both the brachial vein, shown here, and the basilic vein. As you're skinning down the anterior arm past the elbow, you'll notice two superficial veins of the arm and forearm. Those veins are both the basilic, which is on the medial aspect of the arm in this case, and the cephalic vein running along the lateral aspect of the arm and into the delta pectoral groove. Notice how the basilic vein pierces the brachial fascia right here at the basilic hiatus. That's the point at which it changes from a superficial vein to a deep vein so that it can unite with the brachial vein to form the axillary. And here in the antecubital region is the median cubital vein, which is a connecting vein between both the cephalic and basilic veins. This vein is a very common site for venipunctures. Now it's time to tackle what is often a very daunting concept, that is the brachial plexus. The brown boxes shown here to the right represent the last four cervical vertebrae and the first thoracic vertebra. And emerging through their intervertebral foramina are spinal nerves C5 through T1. The brachial plexus in general is comprised of roots, trunks, divisions, cords, and branches. If you're into mnemonics, you might remember the mnemonic Robert Taylor drinks cold beer in order to help you remember the regions of the brachial plexus. Let's begin with the roots of the brachial plexus shown here in yellow. These roots are formed by the ventral rami of C5 through T1 spinal nerves. In the neck, these roots emerge from between the anterior and middle scalene muscles. The dorsal scapular nerve, which you are already familiar with, branches from the C5 root, and it heads towards the back to innervate two muscles, the levator scapulae muscle and the rhomboids. You'll also notice that the long thoracic nerve receives contributions from C5, C6, and C7. And as you already know, the long thoracic nerve is responsible for innervating the serratus anterior muscle. After the roots come the trunks, shown here in purple. There is the superior trunk, the middle trunk, and the inferior trunk. The superior trunk is formed by the union of the C5 and C6 roots. The middle trunk is a continuation of C7, and the inferior trunk is formed by the C8 and T1 roots. A major branch coming from the superior trunk is the suprascapular nerve. And as you might recall, this nerve is responsible for innervating both the supraspinatus and infraspinatus muscles. There is also a smaller and less significant nerve called the nerve to the subclavius muscle, which supplies the subclavius muscle which resides just underneath the clavicle. Of all of the nerves of the brachial plexus, this nerve is the least important. Each of the trunks in purple give rise to an anterior and posterior division. All of the posterior divisions unite to form the posterior cord, and the anterior divisions of the upper and middle trunks form the lateral cord, while the anterior division of the inferior trunk is continuous with the medial cord. When you consider this organization from an embryology perspective, the anterior divisions will supply the flexor compartments of the arm and the forearm, while the posterior divisions will supply the extensor compartments. The cords, shown here in pink, are named according to their relationship with the axillary artery. The posterior cord, for example, is situated behind the axillary artery, whereas the lateral cord is on the lateral aspect of the axillary artery, and the medial cord is on the medial aspect of that artery. There are two terminal branches of the posterior cord. Those branches are the axillary nerve and the larger radial nerve. The axillary nerve innervates the deltoid and teres minor muscles, while the radial nerve will course through the posterior arm and forearm to innervate the extensor compartments of both the arm and forearm. The remaining three branches of the posterior cord include the upper, middle, and lower subscapular nerves. The upper subscapular nerve innervates the subscapularis muscle. The middle subscapular nerve is also known as the thoracodorsal nerve, which innervates the latissimus dorsi muscle. And the lower subscapular nerve will innervate both the subscapularis muscle and the teres major muscle. Arising from the proximal end of the medial cord is the medial pectoral nerve that innervates the pectoralis minor and major muscles. Near the terminal end of the medial cord are the medial cutaneous nerves of the arm and forearm. You may also hear these nerves referred to as the medial brachial cutaneous nerve or the medial antebrachial cutaneous nerve, which represents the medial cutaneous nerve of the arm and forearm, respectively. The lateral pectoral nerve, which innervates the pectoralis major muscle, arises from the lateral cord of the brachial plexus. The remaining three nerves are considered to be the terminal branches of the lateral and medial cords. The musculocutaneous nerve innervates the flexor compartment of the arm, and after it innervates those muscles in the flexor compartment of the arm, it continues on as the lateral cutaneous nerve of the forearm. You'll see a better example of this in just a moment. The ulnar nerve supplies the muscles of the forearm and the hand, and it comes from the medial cord. And lastly, the median nerve is formed by the union of the lateral and medial roots, which come from the lateral and medial cords respectively. The median nerve will supply the muscles of the forearm and hand. If this wasn't painful enough, I now want to write in the nerve root levels from which each of these nerves are derived. While the majority of this is logical, some memorization will be needed. And in general, recognize that as long as you can draw out the entire brachial plexus, you won't have to memorize the majority of the spinal cord levels because you can draw it out and visualize it logically. The reason that I want you to know these spinal cord levels is because it is very useful for localizing nerve lesions and for understanding brachial plexopathies. Let's begin with the dorsal scapular nerve. As you can see, the only spinal root that it comes from is cord level C5. Next is the suprascapular nerve. You know that the superior trunk is formed by the union of C5 and C6. Therefore, it contains fibers from both C5 and C6. The lateral pectoral nerve, because it also receives contributions from the posterior division of from the anterior division of C7, it will include C5, C6, and C7. Therefore, any terminal nerve originating from the lateral cord must also contain C5, C6, and C7 nerve fibers. The median nerve will contain all cord levels, C5 through T1, because it also receives contribution from the medial cord, which is derived from C8 and T1. The ulnar nerve comes only from the medial cord, therefore it contains only C8 and T1 fibers. Likewise, the medial pectoral nerve only comes from the medial cord, therefore it can only contain C8 and T1 nerve fibers. And as has already been mentioned, the long thoracic nerve is derived from C5, C6, and C7. Up to this point, all of those nerve root contributions were logical. Now let's take a look at the posterior cord, which is not necessarily logical or intuitive, but this one has to be kind of memorized. The first nerve here is the axillary nerve. It receives contributions from C5 and C6. The radial nerve, just like the median nerve, will receive all contributions from C5 through T1. The upper and lower subscapular nerves will receive contributions from C5 and C6, whereas the thoracodorsal nerve receives contributions from C6 through C8. I personally think it's easier to remember some of this if you can recognize where some commonalities exist. Let's use the rotator cuff muscles and their innervations. Recognize that all of the nerves innervating the rotator cuff muscles are coming from C5, C6 spinal cord levels. The supraspinatus and infraspinatus muscles of the rotator cuff are innervated by the suprascapular nerve, which comes from C5 and C6. The teres minor muscle is innervated by the axillary nerve, which is also C5 and C6. And the subscapularis muscle is innervated by both the upper and lower subscapular nerves, which again are also derived from C5 and C6. So if you think about it in that way, the only nerve cord level that you'll have to likely memorize is the thoracodorsal nerve, coming from C6 through C8. I cannot emphasize enough that the brachial plexus is the linchpin to understanding the upper extremity. So please, by all means, draw out the brachial plexus from memory again and again and again. And once you are able to draw out the brachial plexus from memory without the aid of your notes, the next step would be to start to draw X's through different regions of the brachial plexus. And by doing that, it will force you to think about the downstream deficits that could occur if there's a lesion in the area of the X. Again, the sooner you understand the brachial plexus, the sooner you'll understand the upper extremity as a whole. Here's the brachial plexus in situ. With this image, I simply want to point out that the divisions of the brachial plexus lie just deep to the clavicle, as shown here. And the cords of the brachial plexus lie just deep to the pectoralis minor muscle. In lab, you'll be looking for the M at the lateral border of the pec minor muscle. This M, shown here, represents the musculocutaneous nerve, the ulnar nerve, and the median nerve. If you start at the M, you'll be able to easily navigate your way through the rest of the brachial plexus. Here is a better view of the posterior cord and its branches. Notice the axillary nerve coursing through the quadrangular space. Don't forget that it courses around the surgical neck of the humerus in company with the posterior circumflex humeral artery. From this perspective, we can also appreciate the upper, middle, and lower subscapular nerves, shown here. The upper and lower subscapular nerves will innervate the subscapularis muscle. Don't forget the lower subscapular nerve also innervates the teres major muscle, as you can see a branch coming down here to innervate the teres major. The middle subscapular nerve also goes by the name of the thoracodorsal nerve, and as you already know, that nerve is responsible for innervating the latissimus dorsi muscle. If the brachial plexus is injured from either trauma, compressive hematoma, or inflammation, for example, there are going to be downstream consequences in the form of sensory deficits, muscular weakness, potentially atrophy of muscles, and even pain. So let's take a moment and let's look at two classic examples, a lesion of the upper trunk and a lesion of the lower trunk of the brachial plexus. Lesions of the upper trunk typically result from a traumatic event in which the angle between the neck and the shoulder is dramatically increased. One example would be mixing alcohol with skateboarding. Another example would be a difficult delivery. If shoulder dystocia occurs during delivery, in which the baby's head is delivered, but the baby's shoulders remain stuck, excessive traction on the head to remove the shoulders can stretch the upper trunk of the brachial plexus. And just as an aside, the word dystocia means slow or difficult labor or birth. Patients who suffer from these types of injuries can present with Erb's palsy. In this condition, the patient's arm is medially rotated, hangs at the side, The forearm is pronated and the wrist is flexed. This is also known as the waiter's tip position. Because Erb's palsy affects the upper trunk, nerves that originate from C5 and C6 are affected. Now let's take a moment to visualize how injury to the upper trunk of the brachial plexus, as shown here by the X, would result in the condition of Erb's palsy. In this condition, patients lose the ability to abduct their arm. As you might recall, the supraspinatus and deltoid muscles are both responsible for arm abduction. The supraspinatus will abduct the arm the first 10 to 15 degrees, and from there onward the deltoid takes over. The supraspinatus is innervated by the suprascapular nerve, which, as you now know, originates from cord levels C5 and C6. Similarly, the axillary nerve, which innervates the deltoid muscle, also contains fibers from cord levels C5 and C6. Because of the point of lesion, information is not being conveyed to either the suprascapular nerve or the axillary nerve. And so as such, the arm hangs at the side. Patients with Erb's palsy are also unable to flex their arm and forearm. This is due to the fact that the arm flexors are innervated by the musculocutaneous nerve, which originates from C5, C6, and C7. In this case, the C7 fibers are not affected. However, both C5 and C6 fibers are. To a much lesser extent, the deltoid muscle also assists in flexion of the arm. And as we already know, that's innervated by the axillary nerve, which was compromised in this instance because it's innervated by C5 and C6 as well. The musculocutaneous nerve also innervates the brachialis muscle and the biceps brachii. Both of those muscles participate in forearm flexion, and so as such, you would have difficulty flexing your forearm if you had Erb's palsy. Not only does a patient with Erb's palsy have an arm hanging at the side, but these patients also have their arms medially rotated. This is because the lateral rotators are out. Recall that the infraspinatus muscle is the most powerful of the two lateral rotators. The less powerful would be the teres minor muscle. Recall that infraspinatus is innervated by suprascapular nerve. We've already seen how that nerve has been affected by this injury. And recall that the teres minor muscle is innervated by the axillary nerve. And again, we've already seen how that nerve is affected by this injury as well. In these patients, they often present with an extended forearm that is also pronated. This is a result of unopposed contraction. Recognize that the biceps brachii muscle, again, is innervated by the musculocutaneous nerve, which is affected in this condition. The biceps brachii muscle is actually a powerful supinator along with the supinator muscle, which is innervated by the radial nerve. So because the biceps brachii are affected here, the amount of supination that can occur is drastically reduced, resulting in a pronated arm instead of a supinated forearm. And lastly, these patients tend to present with a flexed wrist, which gives them that waiter tip appearance. It is also possible to injure the lower trunk of the brachial plexus by overstretching one's arm, which would affect the nerves derived from C8 and T1. Because the ulnar nerve is responsible for innervating the majority of the muscles of the hand, patients with Klumpke's paralysis tend to present with a claw hand deformity. For the time being, I want you to recognize that the ulnar nerve is the main nerve affected by a lower trunk lesion. You're not ready to learn about Klumpke's paralysis just yet, so I'll reserve that for a later video. Thoracic outlet syndrome is a condition in which the nerves of the brachial plexus and even the nearby axillary artery and/or vein become compressed. Neurogenic compression is the most common and presents as pain, paresthesia, and even muscle weakness of the upper limb. Compression of the subclavian or even the axillary vein is also possible, and it may lead to edema of the upper limb, cyanosis of the limb, and a heaviness of the arm as a result of retaining fluid. Recognize that there are three potential sites where neurovascular structures can become compressed. One site would be the interscalene triangle, where both the brachial plexus and the axillary artery are emerging between the anterior and middle scalene muscles. Another site would be the costoclavicular space, which is the area between the clavicle and the first rib below. And the third potential space of compression is the subcoracoid space, the area where the pectoralis minor muscle arches over top of the brachial plexus and the axillary artery and vein. Let's first talk about compression at the interscalene triangle, where the roots of the brachial plexus and the axillary artery emerge from between the anterior and middle scalene muscles. Extreme enlargement of these muscles, from bodybuilding for example, would be enough to cause thoracic outlet syndrome. Also, you might recall that some patients have an extra rib called a cervical rib. In the case of a cervical rib, the rib can impinge upon the lower roots of the brachial plexus and can even impinge upon the artery as well. Surgical treatment options include surgical decompression of the area. One example would be a costoclavicular ligament resection to decompress the subclavian vein, for example. Recall that the costoclavicular ligaments span between rib 1 and the clavicle, and by rupturing or severing that ligament, you can decompress the subclavian vein, shown here. If a patient does have a cervical rib, then a cervical rib resection could be performed. Another option would be to inject the scalene muscles with Botox in order to relax them so that they're not impinging upon the roots of the brachial plexus. And then lastly, an interscalene block can be used to anesthetize the roots of the brachial plexus to reduce the pain. Compression causing thoracic outlet syndrome can also occur between the clavicle and the first rib at the costoclavicular space, and instead of impinging upon the vein, it could actually impinge upon the artery and part of the brachial plexus as well. This is considered to be a chopstick-like compression. And the third area of potential compression is at the subcoracoid space, which is just deep to the pectoralis minor muscle, shown here. This is a site of compression for the axillary artery and vein in particular, and also recall that the cords of the brachial plexus wrap around the axillary artery at this location, so they could be impinged as well. Now let's progress distally from the axilla into the arm. Unlike the brachial plexus, the arm is very straightforward. It is divided into an anterior and posterior compartment, and those compartments are divided by an intermuscular septum. In the cross-sectional image, the green represents the anterior compartment, while the blue represents the posterior extensor compartment. And notice this intermuscular septum spanning from the superficial fascia to the humerus, dividing these two compartments. In total, there are 3 muscles of the anterior flexor compartment of the arm. Those muscles include the biceps brachii, the brachialis muscle, and the coracobrachialis muscle. And recognize that all 3 muscles are innervated by a single nerve called the musculocutaneous nerve. And you now know this nerve originates from C5 through C7. The extensor compartment has one major muscle, and that is the triceps brachii muscle. There's also a smaller muscle called the anconeus muscle, which we'll address just briefly. The extensor compartment of the arm is innervated by the radial nerve, which, as you recall, receives its origin from C5 through T1. The biceps brachii muscle is a weak flexor of the arm, but is a very powerful flexor and supinator of the forearm. It is the screwdriver muscle. So whenever you're using a screwdriver to tighten a screw, you're mostly using the biceps brachii muscle to help supinate the forearm. The tendon of the long head of the biceps is going to attach to the supraglenoid tubercle, that small bump at the top of the glenoid fossa. whereas the short head of the biceps brachii muscle will attach to the coracoid process, as shown here. In the forearm, the biceps brachii crosses the elbow joint and it attaches to the radial tuberosity, shown here, on the radius. Because of its radial attachment, it is able to help supinate the forearm in conjunction with the supinator muscle. Within the cubital fossa, the biceps brachii muscle sends off a bicipital aponeurosis, shown here. This aponeurosis acts as a tent or a roof to protect both the brachial artery and the median nerve. This bicipital aponeurosis blends with the antebrachial fascia of the forearm. If a neurologist wanted to test spinal cord levels C5 and C6, he or she could attempt to elicit a biceps reflex. To test this reflex, you simply strike the biceps tendon here with the patient's forearm in a slightly flexed position. If the reflex is intact, slight flexion of the forearm will occur. One day my grandfather went outside to change the oil in his car, and when he lifted up the hood of his car, he heard a pop in his shoulder, and he lost strength instantaneously in his forearm. Upon going to the doctor, he learned that he had ruptured the tendon of the long head of the biceps muscle. When this happens, the tendon slides down in the bicipital groove, and you get a balling of the muscle belly as shown here, and this resembles the character Popeye, and so it's often referred to as a Popeye deformity. If treatment is sought immediately, the ruptured tendon can usually be surgically reattached. Just deep to the biceps brachii muscle, you'll find both the coracobrachialis and the brachialis muscles. To visualize these muscles in lab, you'll need to move the biceps brachii to one side or the other. Whatever you do, do not transect the biceps brachii in lab. Keep it intact. The coracobrachialis muscle, as its name implies, will attach from the coracoid process above down to the humerus, the brachium in other words. The word brachium simply means arm. Because the coracobrachialis muscle only crosses the shoulder joint, that means it only acts on the shoulder. It's going to participate in arm flexion, and it will also assist in arm adduction. The coracobrachialis muscle happens to be an important landmark for locating the musculocutaneous nerve, shown here. Notice how the musculocutaneous nerve exits directly through and pierces the muscle belly of the coracobrachialis muscle. And again, the musculocutaneous nerve will be responsible for innervating the coracobrachialis, the brachialis, and the biceps brachii, all three muscles of the flexor compartment of the arm. And the third muscle of the arm is the brachialis muscle, shown here. This muscle is responsible for flexing the forearm at the elbow joint. It inserts onto the ulnar tuberosity. This tuberosity is found just deep to the bicipital aponeurosis. Recall that during pronation and supination, the ulna is a stationary bone, whereas the radius is the mobile bone. Because the brachialis muscle attaches to the stationary bone, it does not participate in supination or pronation. However, because the biceps brachii muscle attaches to the mobile bone, the radius, it does participate in supination. After the musculocutaneous nerve pierces the coracobrachialis muscle, it courses between the brachialis and the biceps brachii muscles. And then notice how it emerges on the lateral side of the forearm. At this point, it has already given off all of its motor components and is purely sensory now, and so it becomes a cutaneous nerve, and it changes names to the lateral cutaneous nerve of the forearm. I'll abbreviate that as follows. As you can appreciate from this image, the lateral cutaneous nerve of the forearm is responsible for conveying cutaneous information from the lateral side of the forearm in the area of the C6 dermatome. This is a reminder that knowing the dermatomes of the upper limb will be important for being able to localize nerve lesions in this block. Now let's discuss the major muscle of the posterior extensor compartment of the arm. The triceps muscle is innervated by the radial nerve, as shown here, just before the radial nerve enters into the spiral groove. This is important clinically because if you have a patient with a distal fracture of the humerus, you should expect that patient to be able to extend his or her forearm against resistance because the innervation to the triceps is still intact. That's because the innervation to the triceps has occurred well above the level of the fracture. And to reiterate, the sole function of the tricep muscle is to extend the forearm. The anconeus, as shown here, is a small triangular-shaped muscle of the posterior arm, and it assists the triceps with forearm extension, and it also tenses the capsule of the elbow joint to prevent it from becoming pinched during elbow extension. The brachial artery provides the main arterial supply to the arm and is a continuation of the axillary artery. As a reminder, the brachial artery begins at the inferior border of the teres major muscle, in this location here. The brachial artery ends in the cubital fossa deep to the bicipital aponeurosis, where it divides into both the radial and ulnar arteries. The brachial artery can often be palpated just medial and deep to the bicipital aponeurosis. The brachial artery has many muscular and nutrient branches. However, the profunda brachii, the deep artery of the arm, is the largest branch of the brachial artery. The deep brachial artery courses in company with the radial nerve in the spiral groove. As such, it passes posterior to the midshaft of the humerus. And the profunda brachii will terminate by ending as collateral branches. These collateral branches will meet up with recurrent branches which surround the elbow joint. Before we end this video, I would like to show you one approach to drawing the brachial plexus. Always begin with the roots, C5 through T1. Next, you'll draw two Ys laying on their side. Thirdly, draw another Y in the middle in the opposite direction. Now draw a sideways W which connects the outer Ys. Next, draw an X between the upper and middle Y, and draw a slash between the middle and lower Y. Now let's start to label some of these nerves. Let's start with the terminal branches. MC represents the musculocutaneous nerve. M represents the median nerve, and the U represents the ulnar nerve. The terminal branches of the posterior cord of the brachial plexus include the axillary nerve and the radial nerve. Now let's label the cords. The upper cord here is referred to as the lateral cord. The posterior cord again terminates as the axillary nerve and the radial nerve. And here's the medial cord. That means that this represents the superior trunk, the middle trunk, and the inferior trunk. If we look at that very top Y laying on its side, there are three nerves that come off of it. One nerve comes off of each region. So there's one nerve coming off of the root of C5, there's one nerve coming off of the superior trunk, and there's one nerve coming off of the lateral cord. The nerve off of the root of C5 is the dorsal scapular nerve. The nerve coming off of the superior trunk represents the suprascapular nerve. and the nerve coming off of the lateral cord represents the lateral pectoral nerve, abbreviated LPN. Coming from the posterior cord, there are 3 branches, 1, 2, and 3. These branches represent the upper, middle, and lower subscapular nerves. There are also 3 branches coming from the medial cord, 1, 2, and 3. The most proximal of these branches represents the medial pectoral nerve. The middle branch represents the medial brachial cutaneous nerve, and the most distally located branch represents the medial antebrachial cutaneous nerve. And don't forget that the long thoracic nerve is derived from 3 cord levels, from C5, C6, and C7. And finally, the only nerve that we're missing is that nerve of least importance, which I'll color here in purple, and that was the nerve to the subclavius muscle. You really don't need to worry about this nerve. So that's how you draw out the brachial plexus. Hopefully now this task is a little less daunting. This concludes the lecture on the axilla and the arm. Let me stress again the importance of knowing the brachial plexus. On the exam, you'll get a number of nerve lesion questions, and the only way you'll be able to answer those questions is by having a very firm understanding of the brachial plexus, where those nerves are coursing, which muscles they're innervating, and what clinical signs and deficits result from a lesion of those nerves. So please take a moment to practice drawing the brachial plexus. Hopefully by this time next week, you'll have it memorized. As always, happy studying.